good news is some of the patient engagement issues have kind of been decreased. But the one question that's kind of raised in my mind is in the stage 3 NPRM that came out earlier, they really raised the bar from 5% on patient engagement to 25%. But then in this NPRM modification for stage 2, for the 215 version, is they dropped it to 1 patient. That's really great news for the organizations who are struggling and trying to get there. But I think for the most part, I think it's really good news for the industry, and we're just going to have to take time, kind of wade through it and see how it all fits together with all the other ones that have come out, with the interoperability pieces with the SGR fix, with the Congressman Burgess's bill that may come out related to interoperability, and then the NPRMs for both for stage 3 and for the new 215 configuration rules. Having a 90-day attestation period for 2015 is good, but we have to keep in mind from a timing perspective is when the final rule is going to come out is going to be September. If we all run through everything, and so then it means that if we have to, our vendors have to respond to some of the changes that may make requirements of the software they're going to have to make, and I still think we may be pushed up against the end of the year quite a bit, because one of the things we ran into with the 2014 version is the vendors just didn't have enough bandwidth, particularly on the ambulatory side, to get everything upgraded because of the number of customers they have, and so we may very well run into that, but we're still looking at the timing on all that. I don't think it's the fact that someone is intently or purposely saying we're not going to share data or we're going to make it hard. I think it's because the work is hard itself, and the fact is there's not that many people that really know how to do this, because just because you may know what the HL7 code is doesn't mean that you can actually take care of it effectively, because you can make a mess out of it easily. But there's also a real dearth of standards related to how we do this, and that's one of the things that we're making recommendations, or did, in the our response back on the interoperability roadmap to ONC. The other thing that I'm going to pitch to you that is I'm very passionate about is one of the things that makes it very difficult to do is the lack of a national patient identifier or a patient identifier that will positively identify that patient. I look at the patient identifier as grease in order to make the data flow better. And the other thing too is we can secure it. I've got some friends back in Indiana. She has a sister-in-law that is exactly her same age, that has exactly the same name, but their middle initials are M and W. And their birthdays are 2 days apart, same year. And inevitably, when they go into the hospital, they mix their medical records up. And one has end-stage renal failure, and the other one has a very severe anaphylactic reaction to antibiotics. Well, so if you mix them up, you can kill either one of them very quickly, giving the wrong medications. And so we have to be very careful about that. And I think that in the technologies we have right now, I think we have ways of protecting the privacy. We're currently working on the criteria right now, because there's a process you have to go through to make sure that you're not raising the bar too high or making it too low to get to, and that the criteria is appropriate for the prize. And we have full intention of awarding that prize. We've all had conversation with companies that already believe that they've nailed it. Well, if that's the case, that's great. So let's get the criteria done, and we'll have that out by about midsummer.